Okay, welcome everyone. This is NIH Collaboratory and PCORNet Grand Rounds. I'm Richard Platt. I have the privilege of moderating today's session. John Casey, who is a veteran of Grand Rounds, is going to lead our discussion today. And you can see from his title that he's going to be talking about the new and improved capabilities for REDCap. So, John, thanks so much, and we're all looking forward to learning about this.
Thanks, Dr. Platt, and thanks for having me. So, as mentioned, I am based here at Vanderbilt. I'm assistant professor of pulmonary and critical care medicine here. I'm co-PI of the Vanderbilt Trial Innovation Center and direct the coordinating center for the Pragmatic Critical Care Research Group. And I'm going to talk to you today and take credit for a big group's work, the REDCap Advanced Randomization Module, a trial innovation network project to support the needs of modern trials. I'll just pause here briefly for the conflicts of interest and then show you our agenda. We're going to talk today about platform, adaptive, pragmatic, and decentralized trials. We'll review what problems they're trying to solve. We'll talk about the requirements of a randomization system to support those advanced trial designs. Then we'll talk about the randomization functions in REDCap, the historic functionality, and then the design and release of the REDCap Advanced Randomization Module, which has new capabilities I'm excited to tell you all about. And then we'll get to what I think is really the toughest question for clinical trial efficiency and how the Trial Innovation Network can help with that question. So I'll just repeat again the disclaimer of who I am and who I'm not. I'm a clinician. I take care of patients in our medical ICU and perform procedures like tracheal intubation. I'm one of the co-PIs of the Vanderbilt Trial Innovation Network, and I get the privilege of working on trial methods topics like the ones we'll talk about today. And I run the coordinating center for a pragmatic critical care research group based in acute care conditions, the Pragmatic Critical Care Research Group. And in that capacity, I've had the chance to come talk to this group a number of times in the past about things like our device and pre-oxy trials, but this is a very different topic today. And as a reminder, before we get into it, I'll disclaim that I'm not a biostatistician and not a bioinformaticist. So I'll talk about tools that for which we may have questions that are relevant in those areas, and I'll be quick to acknowledge my limitations in those areas. And although I use REDCap a lot, I wouldn't even call myself a REDCap super user. So let's get into the topic today. So let's start by discussing what traditional randomized trials are. So a traditional trial is a trial in which all trial procedures, including eligibility criteria, group allocation, intervention, and sample size, are specified before the trial and proceed unchanged throughout trial conduct. So there may be interim analyses at which the trial is stopped or not stopped, but otherwise the trial will continue without any changes to the trial itself. I think everyone on the call is or should be familiar with the challenges historically of traditional trials. They're expensive and take a long time. And for all of that effort, they're only designed to answer one question. They rely on assumptions regarding baseline event rates, outcome distributions, and effect sizes. And because of errors in some of those estimates, they're commonly provide results that are uninformative because they're underpowered. They may be affected by imbalances in key baseline characteristics, and patients may have concerns about being randomized to placebos. And many trials have issues where there are patient types who are not included in the trial, and the trial results are poorly generalizable. And for each of these challenges, there are proposed solutions. So to address trial efficiency, people have proposed things like platform trials. Regarding the problems with baseline event rates and underpowered trials, people have proposed Bayesian sequential designs and sample size re-estimation. In terms of addressing imbalances in baseline characteristics or potentially changing allocation ratios, people have proposed adaptive randomization. And then to address generalizability, people often propose pragmatic trials or decentralized trials. And I want to go through these in a little more detail and talk about what each is trying to accomplish and how they try to accomplish it. We'll start with platform trials. So there are lots of different types of platform trials. Some trials are structured around looking at multiple interventions and either adding or dropping arms as the trial progresses based on pre-specified outcome results. Other platform trials randomize patients at multiple points in time or in multiple domains, randomize the same patient more than once. And other platform trials have sequential trials that really have administrative efficiency. But many of these trials are trying to answer multiple questions within either a single trial or a single administrative structure. Adaptive randomization is a trial in which information accrued during the trial from prior participants is used to change the allocation probabilities and change the allocation ratio for future participants. And you can do that for different goals. You might use adaptive randomization to try to minimize imbalances in key baseline variables, to try to increase your power, something called covariate adjusted randomization or minimization randomization. Or you might use data from prior participants to try to increase the allocation towards the arm that appears better in a way that might address ethical concerns or increase recruitment, so-called response adaptive randomization. In Bayesian sequential design, there are frequent interim analysis so that trial continues until there's definitive evidence of efficacy, harm, or futility. And there are other types of adaptive trials, like trials that change their eligibility criteria to try to enrich the enrollment of patients who appear to benefit in the trial, so-called predictive enrichment. I think it's important to highlight that some of these trial structures could be done in any randomization structure, but some, like platform trials and adaptive randomization, have special needs. So what are the needs of a randomization system to support these advanced trial designs, which have been proposed for many years, but became much more common and popular during COVID, and now are being more accepted by regulators, clinical trialists, and even clinicians? So for platform trials, you need the ability to add or drop groups as questions are added or dropped from the platform. And you may, depending on the trial design, need to randomize the same patient multiple times at different domains in the trial or at different points in time. There are a related type of trial called a sequential multiple assessment randomized trial, a SMART design. These designs are trying to test adaptive interventions using defined decision rules for selection of the intervention at each stage. And these inherently require multiple randomizations in the same record at different stages of a patient's course. Adaptive randomization, we mentioned, is this ability to generate a randomization sequence that changes the allocation probabilities based on the knowledge gained from the trial, either baseline characteristics of prior participants for covariate adjusted randomization, or the outcomes of prior participants for response adaptive randomization. And then pragmatic and decentralized trials require the ability for randomization to be conducted without involvement of research personnel. So there might be an example like randomization in the back of an ambulance or embedded in routine care in a rural clinic. REDCap is a secure web platform for building and managing online databases at no cost to nonprofit, made available at no cost to nonprofit, academic, and government organizations. We're very proud that it was created here at Vanderbilt in 2004 and is supported by the NCAT CTSA program. And it's one of the most commonly used platforms for clinical trials. There are nearly 8,000 active partners in 160 countries using REDCap, and it has resulted in 2.4 million projects, over 3.7 million users, and more than nearly 50,000 journal citations. And REDCap's included a tool for randomization that's embedded within the platform since 2012. And we'll start by just talking about what you could historically do with this randomization tool. So it's very user-friendly. You can see at the top right the picture of how it looks. You're in a patient's chart, and you have a very simple randomize button. It allowed a single randomization for each study record and provided really important metadata like time stamping and links to specific users for data audits. And you can see the bottom right that it allowed you to randomize a patient one time on one record, and that randomization that was then locked and had all the important data you needed to know for data integrity of that randomization. The prior tool also had the ability to stratify. So you could stratify by sites or by other key variables like age or sex. But there were capability gaps. So once this randomization schedule was set, it was fixed and couldn't be modified. So you couldn't do things like add or drop a group or change allocation ratios for platform or adaptive trials. You couldn't randomize a study record more than once for platform trials or SMART trials. You couldn't embed models that used the characteristics of prior patients to generate randomization probabilities like an adaptive randomization. And randomization had to be conducted by study personnel with access to the database. And that limited its utility in some decentralized and platform trials. And finally, the inherent functionality was pretty limited in its ability to blind users to group allocation. So I think it's easier to think through some of these limitations if we think about a hypothetical trial. So let's think about a placebo-controlled dose-finding trial of a novel antiarrhythmic following prolonged cardiac arrest that was enrolling patients in the pre-hospital setting. So what would you need to do in that trial? You would need to randomize patients in the ambulance among a very large number of EMTs who are unlikely to be KSP or have the ability to log into a cloud-based randomization system. You might want to blind clinicians using numbered identical med packs. You might choose to design a trial in which you drop the worst performing arm when transitioning from a phase 2 to a phase 3 study, for example. And particularly if there are a small number of patients at a large number of sites, you might want to gain additional efficiency from using adaptive randomization to balance baseline covariates. And you might decide that you want to use Bayesian sequential design to continue the trial until definitive evidence of efficacy, harm, or futility. So which of these trial design components were supported by the historical functionality of the REDCap randomization tool? Well, you couldn't randomize in the back of an ambulance because these users wouldn't have access to your REDCap database. We'll talk more about it, but you couldn't use randomization numbers that would be to link to med packs. You couldn't change the allocation ratio to drop an arm. There was no ability to balance baseline covariates through adaptive randomization, but that doesn't mean that there weren't still advanced trial methods you could that were capable. There was no reason you couldn't do a Bayesian sequential design using the traditional tool. Because of some of these limitations, users have found workarounds. REDCap is really an amazing and flexible program that has a great user base that developed their own tools and to help us identify many of these problems. Some examples of the workarounds that users had used, some of which I had used in my own prior trials, included copying databases to unlock the randomization tool, basically to send the project back to a draft status to allow you to upload a new randomization table for future participants. And this could require this could include all kinds of downsides. So one is effort. There were people who were creating multiple projects and updating the user access to those databases as frequently as weekly. It required either ditching the metadata from the prior trial or having your patients and randomization split across many projects. There were other people who had very sophisticated solutions that were functional but required a lot of effort and expertise to build. So there were people who were custom building randomization tools that provided this functionality, but it required them to do things like manually code an entirely new tool, including manually coding a new randomization button. And it lacked a lot of the embedded data protection. So you wouldn't have the same kind of metadata around randomization that was in the embedded tool. And for many users, these limitations meant that they just used a separate randomization structure outside of REDCap. Our group, the Trial Innovation Network, identified this as an area that we could make improvements, and we convened a group to work on this problem. We first met and started to develop what the scope of work for this project would be in November 2023. We had some design studios where we engaged additional stakeholders to try to refine what the functions of this new module would be. We finalized the plans in April of last year. By September, the REDCap team had built the new module and recruited testers. And then in October of last year, it was released through REDCap version 14.7. And as people may know on the call, REDCap, it has a decentralized structure where sites update REDCap on their own schedule. So this is still becoming newly available to sites as they update the REDCap to version 14.7 or later. And I want to start by saying that I am very fortunate to stand here and take credit for a lot of people. This is the advanced randomization module team, and it includes my Vanderbilt TIC co-PI, Chris Lenzel, Paul Harris, the creator of REDCap, a number of statisticians and program managers, particularly Nan Kennedy, who helped to lead this work. And I want to give a special shout out to Luke Stevens, who was one of the expert REDCap users who had written a lot about this problem and really helped us to think through what solutions might be. He was one of the people who had made a lot of his own solutions and had great ideas for how you could improve the base code of REDCap to help users address all of these problems. Listed here are the new functionalities of this tool that we'll go through in detail. So they include multiple randomizations, improved support for blinding, additional metadata for randomizations, support for pragmatic and decentralized trials, new administrator level allocation management features, so-called hook and extension functions for external modules, which we'll define and talk more about, integration with non-REDCap systems, and a randomization dashboard. So for each of these, we'll talk about what need we're trying to address and how this new module addresses it. So the first is multiple randomizations. So we've talked about how platform trials, adaptive trials, smart trials may require the ability to randomize patients into multiple domains or at multiple points in time. And that requires updating the randomization table for future participants. But you still want to maintain the initial randomization code and all of the metadata for the patients who've already been randomized. And you really would like it to be seamlessly integrated and backwards compatible with the existing tool for projects that are already going or users who have more simple needs and don't need all these fancy features. So how do we meet all of those needs? So we came up with this new ability to create multiple randomization tables, and you can use those in a number of ways. One way is to have multiple randomizations in the same patient. So you can see in this mock-up in the top right that you can randomize the same patient into 2 domains simultaneously, or you could have a second randomization that was only available based on the occurrence of a specific event, like a trial that looked at a rescue therapy where the second randomization would only become available after a patient met pre-specified outcomes. So this allows you to randomize the same patient more than once. It also allows you to change future allocations for a patient who's only undergoing one randomization. And it does that by allowing you to hide your existing randomization and replace it with a new randomization without losing any data about the previously randomized patients. So you could have in your record 3 different randomization codes, 2 of which are hidden and available to the user, but still present for analysis and data integrity, showing who was randomized and the user that randomized that patient, where the change from the user experience is seamless, so they won't notice any difference. The randomization button looks the same to them, even though now this is the 3rd set of randomization allocations. And this system is similar enough to the previous tool that if you're setting up one randomization, the experience is exactly the same for the REDCap managers and study managers who are setting up a single randomization. What about blinding? So it's important to note that blinding isn't an advanced or new trial feature, but it became apparent to us that if we were doing a deep dive into improving the randomization module, we should explore not just adding trials for features for advanced trials, but any inherent limitations that people had noticed even for simple trials. And blinding was in that category. So the inherent built-in REDCap tool by default showed group assignment in an unblinded fashion. And blinding was possible using additional REDCap features. So you could use hidden fields and branching logic, but those were pretty weak protections. People could easily look behind the code and unblind themselves either accidentally or intentionally. And REDCap also lacked the ability to use randomization numbers, and that has limitations. So it can be hard, even if you know the patient's randomization and have the initial randomization table, to simply connect those two and say which randomization was that patient's randomization. It also made it impossible to use randomization numbers to link to individual medication packages, so that weakened the chain of custody. So this new randomization module has addressed those problems and allows the user to either reveal group allocation directly, as they have historically in the original tool, or reveal a randomization number, so that when a user randomizes a patient, they can be shown just a randomization number that can then be given to a pharmacist to look up the group allocation in a lookup table, or you could even have a second project that's within REDCap that you could pipe that allocation to and have just unblinded users in the second project and still have a system that's entirely within REDCap. We also improved the availability and use of metadata. So metadata is information about other data. So We talked about how for randomizations, it's great that REDCap has always had the features that it logs who the user was that performed randomization and the time of that randomization. But those features, while available in REDCap, weren't easily made part of the trial database. So if you had a statistician who exported that code, exported that data, you couldn't easily export all this metadata. You had to go into the website and individually look in records to look at this metadata. Smart variables are a concept REDCap has come up with prior to this project, in which they create variables and link them to specific metadata elements, so that if you want to have your statistician have the ability to export the time of randomization or user who performed the randomization, it's now easy to do that, to have that exportable in your study database. As a pragmatic trialist, this next one is near and dear to my heart. It's something that we've struggled with for a long time. So for some decentralized and pragmatic trials, the trial is designed in a way that allows non-research personnel to perform eligibility, enroll a patient, randomize them, and deliver the intervention. So we already used the example of randomization by an EMS person on the back of an ambulance. Previously, because randomization could only be performed by users with access to the study database, you couldn't do a trial like that using the REDCap tool, and similar limitations exist for most alternative randomization platforms. So that meant that historically, if you were planning to do a pragmatic or decentralized trials that relied on clinicians, you were often forced to use less robust randomization procedures, like physical randomization envelopes, opaque envelopes, or cluster randomization. And it's not the topic of this talk, but each of those have weaknesses that may be less desirable than a patient-level randomization with blinded allocation, where any clinician could perform randomization. So how do we address that? So it's something called trigger logic. So now you're allowed to have randomization be performed when a specific criteria on a previous form is met. So that allows you to embed randomization in a survey that could be accessed by a clinician through a website link that they save as a favorite on their phone, or even through a QR code that's on a poster on the wall. And they then could fill out the first sheet of a survey, which might include things like their name, their location, the study site, confirmation of the patient's eligibility. And then when they submit that survey, they can be brought to the next page. And if the patient qualifies, they would be in real time randomized and have that randomization allocation shown to the clinician in real time. And you can set this up with any functionality you want. So this can be turned off so that you still have to have users go in and click a randomization button. It can be turned on, but limited to a specific set of users. So this is a great feature. We don't want to have to click the randomization button, but we don't want to limit it to a set number of people. Or you can have it available for everyone for the EMT in the back of the ambulance. The next functionality that was recommended to us by the user base was additional abilities for REDCap administrators to do things that may be important but are likely to be rare and not needed for the average user. So there may be times when you need to add or alter a randomization allocation. So for example, there's an internet outage or a REDCap downtime and a patient needs to be randomized. Many studies have downtime procedures like flipping a coin. So now you have a patient who has been enrolled, has been randomized using a study-approved method, and is in the trial. But if you click the randomize button in REDCap, it may show something that's different than what the patient has been randomized to per study procedures and already received. Traditionally, people would deal with that during analysis, but that could lead to errors and confusion, particularly when sharing data at the end of the trial. And there has been a desire to have this randomization sequence in REDCap be the source of truth. So to allow that, the new feature allows REDCap administrators to make changes like manual randomization, remove a randomization, or make a randomization unavailable. It's important to note that these are types of things that have to be carefully explained. So all of these actions are logged and the user and date time are tracked. And these changes require an explanation from the REDCap administrator for why they're making this modification. All right, for the next two functionalities, you'll see how I'm getting out of my depths as a non-bioinformaticist and non-statistician. But it was clear in making this tool and engaging the user base that if you want to do adaptive randomization and change the allocation ratio for future participants, the reasons you might do that and the variables you might use to do that and the methods the limits you set around that are different for almost every trial. But it requires accessing records from prior patients and then running models that have these study-specific goals. So covariate adjusted randomization to balance these key baseline variables that might be different for different trials, or response adaptive randomization to change the outcome, the allocation based on specific outcomes. And obviously, every trial has a different outcome and may have different boundaries around how they want to change their allocation ratio. So it became clear that you couldn't encode one adaptive randomization tool that would address all of these current and future needs. But some of these approaches are reusable or consistent across trials. So how can you make it easier for people to do this and not make them do what they'd done before, which is kind of rebuild this all on their own or use a different system? This general challenge is something that's not new to REDCap, that there are often very special functionality that is specific to a set of trials, but maybe not universally needed enough to embed into the native REDCap code, or will require frequent updates. And REDCap has traditionally addressed that through this external module framework. So people can make their own modules, their own programs that are part of the REDCap universe and can be easily activated at a site or for a specific project and then linked into REDCap. And it allows REDCap users to inject their own custom features. So the new REDCap module has one of these so-called hook or extension functions that can be linked to external modules. So if a specific user wants to build a module to support adaptive randomization in their trial, that can then be shared from any other user for a future trial who wants to do something similar. And I think, as or more importantly, they can accomplish these study-specific goals while still maintaining the protections that are inherent to the REDCap tool, like the metadata and tracking of who performed randomization. And it doesn't require the same level of expertise it did to, for example, recreate and recode the randomization button itself. It's also clear that even that REDCap module may not be flexible enough for some users. There may be users who want to change their approach during the trial or need maximum flexibility. And for that case, the traditional approach of using their own external server and an API tool is still a reasonable option. But in the new version, we've updated the REDCap randomization tool to make it easier to link these API tools in the middle. So still use some of the REDCap features like metadata, like the REDCap protections around metadata, while still building your own custom tool that you can host on your own software. Further, this ability to link an API tool to the REDCap randomization module can also allow you to pull randomizations from the REDCap system into other places that might lack that feature. So, for example, we're exploring connecting electronic health records, which have either no or very weak randomization tools, to these more advanced tools available in REDCap. And then finally, the randomization dashboard. So previously, there was no method of tracking the number of randomizations used. And there is a simple solution, which is just always make vastly more randomization numbers than you think you'll need. But people do still get in trouble. And I have to admit that one of my prior trials, this occurred where we exhausted the available randomizations, and then the tool stopped working because you don't have any more randomization numbers available. The new tool has a dashboard that is available for users who have the appropriate privileges to see how many randomizations have been used and how many are still available. And this can be set up in a way that maintains blinding or would reveal group allocation for an unblinded trial. So let's go back now to our example. So our example trial of a placebo-controlled dose-finding trial of a novel antiarrhythmic following cardiac arrest. So using these new tools, you now could set up a QR code in the back of the ambulance that the EMT could hold their phone up to and be brought to an eligibility survey that asks a couple simple questions, and they press next, and the allocation's revealed. So they couldn't randomize the patient in the back of an ambulance. And what could come out of that randomization could be group assignment, or it could be use this dose pack so that the clinicians remain blinded to the intervention. The new tool would allow you to change the allocation for future patients, to, for example, drop an arm when going from phase 2 to phase 3. It would allow you to use a hook function, an external module, to do things like adaptive randomization to balance baseline covariates. And I'll actually mention that Luke, the REDCap user who helped with some of these functions, has already made the first of these available. So his biased coin algorithm is the first of these external modules that can be hooked to the REDCap randomization module. And then finally, in our example trial, we can still do something that we could always do, which is a Bayesian sequential design to continue until definitive evidence of efficacy, harm, or futility. So this was a pretty simple overview, and obviously we didn't go into a great deal about how exactly you build the randomization tool or which options you select, but there's a lot of additional guidance available online. So first, the REDCap homepage has step-by-step guides that can be accessed via the Visit the Help Resources page, as well as video tutorials accessed from the Training Resources link. And as always, our users are unbelievably quick in identifying new tools and coming up with their own user resources. So one of the best I found, which it was great to see someone explain back to me our randomization module with as much or more clarity than I could have, came from Seattle's Children's Hospital, so, for which I've included the link here. So what are the next steps for this project? We already have a methods and dissemination manuscript describing the things I talked about today that's under review and will be publicly available soon. The randomization module will be incorporated into the REDCap 21 CFR Part 11 validation framework for FDA registration trials. And then, as mentioned, we're exploring methods to support EHR-embedded pragmatic trials and seeing if this REDCap module is the appropriate approach to help support that, or if some other tool is needed. But this is a more specialized need, but I think an important need for future pragmatic trials. All right, so I played coy earlier, so I said, now we get to the toughest question for clinical trial efficiency. And I think it's when to use these design tools. And I'll start with two disclaimers by saying that there's no one perfect trial design, and trial design has to be fit for purpose. And I'm going to give a second disclaimer, which is saying the next few slides are really more my opinion than they are representative of every trialist and leader in the Trial Innovation Network. But I'm going to start by saying, what is efficiency in a clinical trial? The textbook definition of efficiency is output over input. And for a clinical trial, the output is evidence to inform patient care, and the input is money, time, and effort. And why must clinical trials be efficient? Because resources for clinical trials are limited. We only have so many personnel at our coordinating centers, trialists, investigators, coordinators, statisticians, patients, and community partners. So there's only so many trials that they can support. And then further, funding is limited. So the amount of R1s hasn't increased over time, even as things like the salaries of the people doing trials have. And then funding's at risk. And there are obviously many recent examples of funding being limited or cut. So in what ways can a trial be more efficient? So there are a number of axes in which a trial can be efficient. There's logistical efficiency. There's regulatory efficiency, things like simplified consents, SIRBs, standardized contracts and DUAs, and fit-for-purpose models of consent. And there's statistical efficiency, which is a lot of the things we've talked about today. So platform trials, adaptive designs. And I want to say that we're not going to talk about regulatory efficiency today, but I'm going to highlight that one of my friends and colleagues, Stephanie Moraine, as well as Nancy Cass and Ruth Faden, will be giving this lecture next week, addressing very directly regulatory efficiency by talking about fit-for-purpose consent models and improving the ethical oversight of pragmatic clinical trials. So we're going to focus today on this tension around logistical and statistical efficiency. I do think these things can be related. So when we think about statistical efficiency and logistical efficiency, the product of those two is the information learned. So logistical efficiency means how many patients can you enroll for the fixed amount of time and money do you have? And statistical efficiency means what do you do with that information? How much information do you get out of the number of patients you enrolled? And the product of those two, the area under the curve, is how much we've learned to inform patient care. We might think about an early phase drug discovery trial, a 100-patient phase 1 trial of a novel infusion for the treatment of hypotension that's going to enroll at 30 sites, 3 patients per site over a few years. There's real risk when you're enrolling such a small number of patients at a large number of sites that you'll have imbalances in baseline characteristics that decrease the power of the trial. And you might think about something like adaptive randomization to balance baseline covariates, and that might increase statistical efficiency. And further, it would have no real effect on operational efficiency. These patients are very hard to find. It takes a great deal of coordinator effort to identify a patient. Those coordinators are going to collect a great deal of information about the patient, both before and after randomization. And collecting those key baseline characteristics before randomizing the patient to allow adaptive randomization to balance baseline covariates has essentially no cost. So you might make that change, improve your overall information learned having no real downsides. But the same tool might be different when applied in a different setting. So let's think about a trial that has better logistical efficiency, like a pragmatic trial. So let's think about, for example, one of the trials our group is leading now. The RSI trial is a 2,364 patient comparative effectiveness trial of sedative medication during emergency tracheal intubation at 6 sites. And it's being conducted under EFIC. And we'll have in the range of 1,000 different clinicians who randomize patients during emergency tracheal intubation in the ED and ICU. And the period between when they decide the patient needs to be intubated and when they have to make the decision around randomization is on the order of a few minutes. So a very tough time period to embed study procedures, but one in which we've been able to engage clinicians in enrolling their patients in trials. But if I wanted to use the same adaptive randomization to balance baseline covariates, one, because there's such a large number of patients at a relatively small number of sites, the benefit of doing that smaller. And then secondly, there are real costs to that. And so if I ask these clinicians to say, well, before you enrolled that patient, I need you to look up these 3 factors and calculate their Apache 2 score and put them into this randomization sheet so that it can tell you which medication to give, that would be so disruptive to their clinical workflow that they would exclude a much larger number of patients. And we might increase our statistical efficiency, but decrease the total amount of information learned by leading to a less efficient enrollment process. So I think we really have to ensure that all these tools we're using are fit for purpose. And I start with a model of a large simple trial. So a large simple trial just does 3 things. You enroll patients, you separate the groups, and you collect the primary outcome. But there are many other things that you might want to do that for specific trial goals are not just helpful, but might be critical to accomplishing your study goals. And those could include additional pre-randomization data collection. They could include things like adaptive randomization, multiple trial adaptations, ancillary surveys on implementation, extended batteries of outcome collections at 3, 6, and 12 months. But it's also worth noting the more of these features we add, the more impact they might have on logistical efficiency. And I think there are often trade-offs that are unrecognized when we make some of these decisions. So how do we choose between these new available tools that everyone talks about and wants to use and decide when they're appropriate? This is my sales pitch to you. So the Trial Innovation Network, which funded the project we talked about today, exists to help trialists make these kinds of choices. So the TIN is an NCATS funded collaborative within the CTSA program, and it seeks to innovatively address critical roadblocks in multi-site research by developing, testing, and supporting innovative operational and recruitment tools like the one we talked about today, but also by offering cost-free structured scientific consultations with clinical trial experts in various diseases across all stages of the disease process. And in this current iteration, there are 3 TIN sites. There are 2 trial innovation networks, one based here at Vanderbilt and one based at Johns Hopkins, and a recruitment innovation center based here at Vanderbilt. And all of these have a number of other partners shown here. This is the process for investigators who choose to seek out help from the Trial Innovation Network. There's a QR code here. You can also just find the group by searching for the Trial Innovation Network online. When you submit through our website, we'll review your proposal and within 5 business days assign it to the most appropriate Trial Innovation Center or Recruitment Innovation Center, have an intro call to understand your needs, and within 30 to 45 days, finish this initial process of trying to help you give you some initial guidance, understand what your needs are. And then for certain projects that need more support or need, for example, a coordinating center, a clinical coordinating center, or a data coordinating center, there's a more longitudinal option where the Trial Innovation Network works with you over a process of 6 or 9 months, even with helping with grant development, and then turns you over to an assigned CCC or DCC upon successful funding. A little data in terms of our consults and resources. We've had 453 consults that have come into the Trial Innovation Network. The majority of those have very specific needs, and we provide resources. Although many of those resources are shown here at right, and they include things like recruitment feasibility assessment, recruitment and retention planning, expression of interest to help you identify new sites, EHR-based tools and resources, engagement studios, recruitment materials, SIRBs, and standard agreements. And then 89 trials have gone through this comprehensive trial process where they get more longitudinal support, and 35 are in this implementation phase, with 10 serving as a data or clinical coordinating center. So since 2016, 431 of those consults have been completed in 77 therapeutic areas, with proposals submitted to 21 NIH ICs. And these proposals have come from 63 different CTSAs, 96% of the CTSAs. You can see here the investigator roles, which are a range of levels of experience from professor all the way down to postdoc fellows at a broad range of therapeutic areas. And in addition to developing new methods like the REDCap randomization module, supporting investigators through our consultation process, we also have these informational tools on evidence-informed resources and tools that are available in our 10 toolbox and available free to all research community members. So thanks again for having me today. I'm glad that we've got a lot of time here to talk about the REDCap randomization tool, or whatever else, whatever other questions people have about the Trial Innovation Network.
John, that was really masterful. Thank you. So let me start off by asking, tell us again, when did this new software make its appearance?
October.
And what kind of reception has it gotten?
Yeah, so I think one thing I'll ask of your members is to please pass on their feedback. So collecting feedback and understanding how users are using it and liking it is always a challenge. I'll say that two positive things: the REDCap user base, which has a robust groups that meet and talk about new tools, have given really positive feedback and have also helped us think about some ways to refine the features. And then, as or more importantly, no one has reached out and said you broke it. So many trials were already using these tools, and the change has been seamless. There's been no one who raised concerns that their prior project has been disrupted by this. And I'll say that I have already used some of these features in our trials that have adapted from pilot phase to multi-center phase, and that's gone well. I'm still waiting for the first trial to use that decentralized pragmatic trial feature of embedding randomization in a survey. So I'm coming here hoping that someone in this audience will do that. And if you don't, then I will soon, so I can report back on how that goes.
And this is self-serve, right? I mean, potential users could contact one of the support services you mentioned, but
Yeah.
you don't have to. You could.
Yeah, we get most excited when we see people using the tools without needing our help. That means we did a good job in designing a simple, easy to use tool and making the resources easily available. And that's the goal, but we absolutely are available both through the TIN and just through traditional the REDCap help, which is both centralized here at Vanderbilt, but it has a centralized process, but it has this decentralized model where there are people who know vastly more about REDCap than me at every hospital across the nation. And for most questions, your local REDCap person can almost certainly help.
Just an editorial comment is thinking back to pre-TCSA days. This is really astonishing. I think if we had, if we had written down the wish list of what we hoped would be available, it would have been pretty close to what you've been describing. So really impressive. Let me say to our Mary Jo and Alex, there is a pair of questions from Alex Capron that I don't think everybody can see at the moment. Can you move those into the answered section? There we go. So Alex has a couple of pretty good questions. So while they're well written, I think Alex, if you'll take the microphone and sort of lead us through your questions, I think we'd all enjoy hearing what John has to say about them. And you're on mute still, Alex.
So the first question, Jonathan, is whether the REDCap team has kept data on the greater acceptability of pragmatic randomized trials with clinicians. I look at this from the viewpoint of ethics. I just think it is such an important thing to have clinicians buy into the idea. But I wonder, are there data? I mean, clearly you described a lot of trials that have gone forward, and I assume that that reflects a growing base of clinical acceptability. But do you have data on that?
Yeah, it's a great question. So the NCATS is always pushing us to say, how do you measure the impact of these tools? These tools are great and sound great. And the easiest thing is users. So we definitely will have the ability to track how many people are using the modules. We'll have to investigate the ability to which we can track the way they use the randomization modules, but it's a good question. There are probably ways for us to do that. I think how clinicians interpret and accept these more advanced randomization features is the hardest. And I will admit that I'm not sure how we could do that, but I'm open to suggestions. But I'll jump in here and editorialize, which is to say, I'm standing here taking credit for a team that's been around for a lot longer than I have. Paul Harris and Rob Taylor have been working on these things for a long time, and I'm very new to the team. I was mainly a user and cheerleader of REDCap until the last few years. But I'll say that as a trialist, I think there are both opportunities and real cautionary tales within adaptive randomization. So I think clinicians are accepting them. And during COVID, there were many trials that used adaptive randomization that were published in high-profile places and were incorporated into guidelines. But they're very adaptive randomization is very complicated, and the biases that it potentially introduces, I think, are poorly understood by clinicians. So I also think that there are people who have some concerns about introducing complexity that might affect interpretation, but that the community doesn't yet fully understand. And the complexity has additional cost in terms of potential mistakes in our field. REMAP CAP has been one of the leaders. Derek Angus had helped establish that field, and they were very honest about a mistake that occurred in their network last year in a steroids trial, where they had a complicated system in terms of their adaptive randomization, and were thinking during the trial that they were increasing allocation towards the steroid arm, thinking it was better, and the coding was backwards. And in fact, they were increasing randomization towards the arm that had harm. So the exact opposite of what your goal might be with a study like that. So that could never occur in one of our studies that has a one-to-one randomization. But when you add these complicated tools, they both increase complexity of interpretation, but they also lead to opportunities for new errors that we haven't even thought of.
Yeah. One of the things that when I was still at USC and hadn't retired, that we did through the ethics consultation process was to talk about these issues, and that was during the era of REMAP CAP and the its use in the COVID treatments. And one of the questions that we heard from clinicians who were not researchers but were willing to consider it was, what happens when I have to intervene because something is going really wrong and I need to know which arm they're in. And I had understood from what you presented, and I just wanted to make sure I did understand that they're able to discover that quite easily if they have to, if they're withdrawing the patient from the study because they feel they have to address the clinical problem. Is that correct? And okay,
So you're getting into, well, I was not in my head excited to respond, but I'll clarify. So you're getting a really important issue, which is it's really happens a lot in our field in critical care because many of the therapies that we use are also used as rescue therapies. So this comes up in steroids and immunosuppressants and all kinds of things where people say, well, I have to have the ability to, I think I have equipoise at this stage of the patient's illness. And I think it's totally appropriate to randomize a patient. But if they get worse to some level, I need to have the ability to intervene and know what to do. And I think that's an ethical mandate. They have to have the ability to do what's right for their patient. And I think trials have to have mechanisms to allow that. And that requires ability, if that's likely to occur, a trial should have protocols about when clinicians should be empowered to do that. And even if a clinician even wants to violate that algorithm, I think that we should allow that, but track that. So I think there have to be mechanisms to unblind the trial. I think that can be done just as easily in an adaptive trial with an allocation ratio that's different to 1-to-1
right.
as in other trials, but I'm not sure in my mind those are linked issues.
Okay. Thank you.
Okay, and I'll second Alex's first question/request. It would be terrific if you would be willing to give us a brief follow-up in 6 months or a year, John, about
And if I may make one, you could pass on to the REDCap people that one of the things they could inquire with people who have used the tool repeatedly is whether they are finding more clinical acceptance. It would be qualitative data because it would be their impression and so forth, but maybe some of them have kept track if they're dealing with clinicians within their system or within their catchment area where they have community physicians.
That's a great suggestion. I think you're totally right. There's lots of work to do in that area.
So I don't want to suggest that we don't properly appreciate everything that you just described to us, but what's on the list for the next version of REDCap?
Well, this is where I'll go back to say I'm not a REDCap super user or a bioinformaticist. So I'm a trialist, and I get to partner with smart people on the REDCap team like Paul Harris and Rob Taylor who have that as their full-time job, and they have lots of things that they're working on. So I'll share a few of the things, and I hope they'll be okay with what I know they're sharing what I know they're working on, but be quick to say this is not my work and not even things that I'm probably could give you great technical detail on. So I think other things that they're working on that have me excited. So they're working on additional ways to support decentralized trials. And one big challenge that has come up that was identified in part by Chris Lenzel through the Active-6 trial was participant verification, that when you have these decentralized trials, how do you know the person you're interacting with is who they say they are? So are there ways to embed systems that do, there are all kinds of ways to verify who you are when you're starting a bank account or filing your taxes. And are there are ways to link REDCap to some of those systems to allow patients to verify who they are for trials where that's critically important? And there have been examples of trials in which there were bad actors. There were people who recognized, hey, I can make $10 by filling out a survey, and I'm going to code a tool to submit a bunch of surveys from Czechoslovakia to have checks sent to me. So I do think there is a role, if we're going to decentralize trials where people have the ability to enroll from anywhere, particularly for recruiting online through social media, identity verification is going to be a more important problem. Another is data sharing. So real-time data availability has been something REDCap's been working on for a long time. And I think those tools are becoming mature and we're seeing them used in more and more trials. And I'm using the so-called CDIS tools in one of our first pragmatic trials. Our mentee, Kevin Seitz, is doing a multi-center trial of mode of mechanical ventilation that will use those features. And we're excited to see how they work to help us in real time have great visibility into things like separation between groups and enrollment rates. And we'll write about that experience afterwards. And then also participant-mediated data sharing. So people who do research like this know that it's so painful to have different sites execute contracts to share data, oftentimes for patients that have already consented to share that data. To me, when a patient signs a consent form and says, yes, please share my data for this trial, institutions, I think, are getting in their way in a way that I think is both impractical and has ethical implications. And the 21st Century Cures Act mandated allowing patients to see and share their data, and they can do that clinically now. And can we use those kinds of functionalities and embed them in REDCap so that they could share their data with investigators in a way that doesn't have to go through the contracts office? So-called participant-mediated data sharing. So I think if I was to think about which 3 features I'm most excited about that they're working on and things that I would like to see available to apply in my own trials, that's the top 3.
That's terrific. Well, you stuck the landing, John. So that's really appreciated. And you did us the great service of advertising next week's grand rounds, which we can now see on the screen. It's going to be fit for purpose ethical oversight of clinical trials. So, John, I hope you can join us for that. And to the other 150 who are online, we'll see you next week. Thanks very much. Bye, everybody.